Good morning to you all. Welcome back to my YouTube classes, YouTube medical classes by Dr. Srinidhi Kumar Acharya. Please don't forget to subscribe my channel and also please give your valuable comments. In the last few classes, we are discussing about some of the case studies related to congenital heart disorders. Especially we have seen two case studies related to congenital heart disease, especially the heart disease, especially acynotic heart disorders we have seen in the last two classes. In detail we have dealt with the case studies. So after completion of two case studies related to acynotic congenital heart disease, now we know everything about acynotic congenital heart disease where cyanosis will not be present. Of course, a cyanotic disorder may be get converted into cyanotic disorder in the later part, but otherwise cyanotic is characteristically absent, and such congenital heart disorders are called as acynotic heart disorders. In 1925, Oslers he is the first person who mentioned four methods of diagnosis like inspection, palpation, auscultation and contemplation, etc. And Osler's notes are also there. And especially for the diagnosis of congenital heart disorders in children, we used to follow the NADA's criteria. Okay, just like in the rheumatic heart disease we have Jones criteria, similarly we have NADA's criteria. This NADA's criteria helps to identify the heart disorders in children, especially congenital heart disorders. Now, NADA's criteria contain two criteria. One is major criteria and another one is minor criteria. The major criteria in the NADA's criteria is systolic murmur. There should be presence of systolic murmur. There should be presence of a diastolic murmur. There should be cyanosis, or there should be CHF. Congestive cardiac failure or heart failure. So major criteria means any of these four or five major criteria should be there. Out of this, if one is present, then also it is considered as a congenital heart disease. See the last line, presence of one major and two minor criteria. So now what are the minor criteria? Systolic murmur, abnormal second heart sound, abnormal ECG, abnormal chest X-ray and abnormal blood pressure. Now, presence of any one of the major criteria and presence of any two of the minor criteria. Suppose a child is having systolic murmur with abnormal ECG and abnormal chest X-ray. Now, this helps to diagnose the congenital heart disease in the children. So, we have to diagnose that case as congenital heart disease. So, that's all about NADA's criteria, which helps to divide these congenital heart disorders. Now come to the basic topic, acynotic heart disease. Now acynotic heart disease, we have seen two important cases, long cases related to this. One is acynotic heart disease associated with the Down syndrome, and another one is acynotic heart disease with the VSD. Now to identify the acynotic heart disorders, history is extremely important. What is important is history. Now, what type of history you want to take? Now, especially the feeding difficulties. We have seen in the last two cases, suck, rest, suck cycle. Our mother is telling that my child is taking too much of time to complete the breastfeeding or empty one breast. So these are some of the important clues for the diagnosis. So feeding difficulty, okay? Or easy fatigability. One more is easy fatigability. Child is doing some activity or child is sucking for some time, doing some activity and then again get dyspneic. Now this is again characteristic. We know that because of the hyperdynamic circulation, pulmonary edema, etc. So there is a dyspnea and it leads to easy fatigability. Exertional dyspnea, that will be there. And there will be repeated respiratory tract disorders. Now this is a very important history. Repeated respiratory tract disorders. We know that Acynotic heart disorders in which there will be hyperdynamic circulation that leads to increased pulmonary circulation, collection of the blood in the lung parenchyma, or fluid overload there, pulmonary hypertension, fluid stasis will be there, and mucus secretion will not be cleared. There is hypertrophy of the mucus gland leading to more and more secretions which is not get cleared, and there is collection of the mucus plug, and that leads to repeated respiratory tract infection, especially lower respiratory tract infection. So that is one of the very important history. Now, acynotic congenital heart disorders may be there in some of the other conditions like the maternal disease. Suppose if there is maternal disorder, so for example diabetes. Now you know the heart problems are one of the most common problem, congenital abnormalities associated with the diabetes mellitus. Always when the mother is having diabetes mellitus or treated for diabetes mellitus or under treatment during the pregnancy, it is must and should that you have to screen the baby for heart disorders, heart disease, because this is one of the most common congenital problem which can occur in a diabetic mother is a cardiac problem, congenital cardiac problems. So this may be there is the mother is suffering from SLE, systemic lupus erythematosus. Mother is suffering from phenylketonuria like metabolic problems, or if the mother is taking some of the drugs, especially antidepressant drug. Mother is taking some of the antidepressant drug. If the mother is having some psychological problem and she has been treated with the antidepressants and all, and it is one of the major cause for acynotic congenital heart disease. So definitely the fetus may develop a congenital heart disease or type of acynotic congenital heart disorders. Now we know that infections during the pregnancy, especially maternal infection, they are another important major cause, especially any infection which is occurring in the first trimester of the pregnancy, like maybe rubella, maybe varicella, chickenpox, or sometimes torch infections. Okay, so they are all the potential cause for the congenital heart disorders during the pregnancy, congenital heart disorders in the fetus. So this much of a history is very important. Some other part related to history is, so why history is important? Because the history gives the richest information without doing any much investigations. If your approach is good, history will give so many information and you will directly into the diagnosis. Only thing is we should know some of the basics and we should know the approach. Okay, now in cardiac disease the present history should include, so whenever you take the history in cardiac disorders for congenital heart disorders, what are the important history that you have to take apart from the facts which is explained in the last slide? Some of the other things that you have to always ensure is symptoms of any pulmonary venous congestion. Just ask, that means just assess whether there is any pulmonary venous congestion, that means whether there is any overflow of the blood in the pulmonary bed, so that the pulmonary bed is over congested. Okay, like, so what will be the symptoms related to this pulmonary venous congestion? Pulmonary venous congestion, why it occurs? We know that because left ventricle, right ventricle. Suppose if there is a VSD, one of the acynotic disease, blood from the left ventricle go to the right ventricle. So right ventricle is receiving more amount of the blood than the normal. So that blood has to be pushed up, and that will be pushed into the pulmonary trunk. Pulmonary trunk opens into the lung, and our lung is over flooded. So that leads to pulmonary venous congestion. And the symptoms of this pulmonary venous congestion is maybe dyspnea, there may be orthopnea, sometimes there may be paroxysmal nocturnal dyspnea. Okay, so cardiac asthma, then cough, hemoptysis. So these are all the symptoms of pulmonary venous congestions. Then you also look into symptoms of the pulmonary symptoms of low cardiac output. Low cardiac output, that means there is no blood coming into the left ventricle for the cardiac output. Okay, so if the blood is coming to the left ventricle, then it will be pushed into the aorta and all over the body it is circulated. Now if there is some such congenital malformation where the blood itself is not reaching the left ventricle, okay, maybe there is some problem in the left atrium, there may be some problem with the pulmonary veins which is coming from the lung to the left atrium. Sometimes there is anomalous pulmonary vein will be there. Pulmonary vein, instead of getting opening into the left atrium, sometimes it get opened into right atrium. Opens into right atrium. This is anomalous pulmonary veins. So in such cases, what actually happens is your left ventricle is not receiving the blood at all, and that is how can it push the blood now? Okay, so that definitely leads to low cardiac output. So low cardiac output will be, there will be fall in the blood pressure, and there may be anemia, like symptoms will be there. Now, some of the other symptoms that you have to look in is chest pain, and then the cyanosis and jaundice. Okay, now if you look into the palpitation, yes, palpitation is one of the important things. What do you mean by palpitation? Awareness of one's own heartbeat is called as palpitation. Okay, palpitation. So palpitation also suggests the overfunctioning left ventricle due to various causes. Now, symptoms of the peripheral vascular disease. Now you have to also look into some of the symptoms related to peripheral vascular disease. Maybe there is venous thrombosis and all those things. Okay, then you have to look into some of the toxic symptoms if it is present. So congenital heart disease are broadly divided into acynotic and cyanotic heart disorders. With these are the points that you have to collect from the history. Now with this background, now we can say totally congenital heart disorders are divided into two basic groups. One is cyanotic and another one is acynotic. So first we will see what do you mean by cyanotic congenital heart disease. So, cyanotic heart disorders can occur at different level. Number one is acyanotic heart disorders can occur at different level. Now, one of the classification of acyanotic disease is simple left to right shunt cases. Okay, suppose the patient is having a VSD, ventricular septal defect. Blood from the left ventricle is coming to the right ventricle. As the muscle mass in the left ventricle is more, so flow of the blood is from the left side to right side, and as a result there is a left to right shunt. As the pure blood is mixing with the impure blood in the ventricles, so there is no development of the cyanosis, and we will call it as acyanotic type of VSD. This is one important cause. Now acyanotic congenital heart disease also includes at a atrial level. Atrium, right and left atrium. What are the atrial level? At the atrial level, the most common is AST. Okay, at the atrial level, the most common is AST. Now, at the ventricular level, yes, we have already seen ventricular septal defects. Okay, now there is one more type of acyanotic congenital heart disease can occur, that is at the great artery level. Great artery means our two great arteries, pulmonary trunk and as well as pulmonary trunk and as well as aorta. Okay, so now at a great arterial level, also there may be acyanotic congenital heart disease in the form of patent ductus arteriosus. If you see the patent ductus arteriosus, it is now connecting the pulmonary trunk with the aorta. Pulmonary trunk with the aorta, it is connecting. Okay, so now blood which is going to pulmonary area, that is to the lungs, will be bypassed directly into the aorta without purification. That does not suggest that all the blood is not going into the lung. Some amount of the blood is going and getting purified and coming back into the left atrium, from the left atrium to the left ventricle, from the left ventricle to the atrium, and going to the atrium, aorta, and going to the all over the body and circulating all over the body. That means when I say PDA is there, PDA means maximum amount of the blood will be bypassed, or some amount of the blood is going. Okay, so therefore there is no cyanosis. So at patent ductus arteriosus, PDA, or sometime it can aorta pulmonary window or aorta ventricular tunnel syndrome. So that means this particular obstruction can occur at different levels in terms of great vessels. So anyway, VSD, ASDs, and as well as PDA. So these are the three important names that you should not forget whenever you talk about acyanotic congenital heart disease. That's all. And PDA, how to differentiate, we have seen in the last class. There will be a wide pulse pressure will be there, and all the arterial pulses will be bounding or more, and there will be a train internal murmur will be there. Missionary murmur will be seen. S1, S2, both are not heard. It will be now masked by this train internal murmur or machinery murmur. Now to continue, acyanotic congenital heart disorders can be divided into two types now. So this is now we have seen the first basic classification. Now we go further. Now these acyanotic congenital heart disorders can be further divided into two types. One is obstructive type and another one is non-obstructive type and another one is miscellaneous. Okay, so there are basically two or three types: obstructive, non-obstructive and miscellaneous. So there should not be any cyanosis. There should not be the cyanosis. That means blood should be purified. Purified blood is mixing with the impure blood. Okay. So what are the obstructive causes? Yes, acyanotic heart disorders may be there in case of pulmonary stenosis, aortic stenosis, coarctation of the aorta, peripheral pulmonary artery stenosis, congenital mitral stenosis, and pulmonary venous stenosis. See, in all these conditions, pulmonary stenosis, aortic stenosis, COA, coarctation of the aorta, maximum of the conditions, what happening is blood is getting purified. Okay, maximum amount of the blood is get purified. Then purified blood is mixing with the impure blood in the atrium, left ventricle. Okay, pulmonary venous stenosis. That means blood is purified from the lungs and coming through the pulmonary veins into the aorta, into the atrium. And during that time there is some stenosis. So that blood is completely not coming into the atrium and not completely entering into so that the left ventricle is receiving less amount of the blood. Similarly, mitral stenosis. Mitral stenosis means blood is there in the left atrium. From the left atrium, it has to come to the left ventricle, and there is a stenosis. But till left atrium, blood is coming normally. That means left atrium always receives the pure blood. Again, it's a condition of the pure blood. Pure blood, then later pure blood only, but concentration is less because of the stenosis or whatever you say. The less amount of the blood is coming to the ventricle. Therefore, oxygen concentration comes down. Okay. So this is called as obstructive type. I hope you understand. In case of obstructive type, actually there is no much mixing of pure and impure blood. The main thing in obstructive is left ventricle is receiving less amount of the purified blood, as in case of pulmonary venous stenosis, as in case of mitral stenosis. Okay, as in case of pulmonary stenosis. What happened in the pulmonary stenosis? Pulmonary stenosis is there. Therefore, from the right ventricle, blood which is entering into the pulmonary trunk itself is less. Whatever the blood is entering into the pulmonary trunk and into the lungs, that will be purified and that will be given back to the left ventricle and that will be circulated. But what happens, as the amount of the blood is less, the oxygen concentration is not up to the mark, but there is no cyanosis because blood is purified. So that is what is exactly happening in case of obstructive type of acyanotic congenital heart disease. Similarly, some of the conditions are there with the acyanotic congenital heart disorders where the cause is non-obstructive. There is no obstruction. Now in these above cases there is clear-cut obstruction. Sometimes there is no obstruction. What is that? Idiopathic dilatation of the pulmonary artery or absent pulmonary valve. See, these are the two conditions where there may be acyanotic congenital heart disease but there is no cyanosis. The cause is idiopathic dilatation of the pulmonary artery. Pulmonary artery is dilated. Okay, pulmonary artery is more dilated. Then similarly, absent pulmonary valve. Pulmonary valve is not there. These are some of the non-obstructive causes. Similarly, some of the miscellaneous causes are there. Congenital cardiac myopathy, dilatation of the pulmonary artery, absent pulmonary valve, and myocardial fibroelastosis, etc. Of course, these are some of the rarest causes. But anyway, we can divide this cyanotic congenital heart disease into three types: miscellaneous, non-obstructive, and obstructive. Now, let us see this, the extracardiac markers of the congenital heart disease. What are the extra cardiac markers of congenital heart disease. That means you don't have any clue that child is having cardiac problem. Now, by looking at the other symptoms, how you can suspect that this child may have cardiac problem. For example, child with a microcephaly. Okay, suppose child is having microcephaly, because microcephaly most commonly associated with your Down syndrome and all those things. So Down syndrome, 50% of the cases, AV canal defects are common. Okay, or any conditions with dysmorphism, facial dysmorphism always suggest that there will be some syndromic presentation, and many of the syndromes will have cardiac involvement, including the Marfan syndrome. Marfan syndrome also there is involvement. Down syndrome also there is involvement. Patau syndrome also there is involvement of the heart. Williams syndrome is also having involvement of the heart. So many syndromes are there. So whenever you got a clue that this child has got some dysmorphic features, which suggests that there may be some syndromes, then you have to also look into the cardiovascular system. Hypertelorism, again, is a part of facial dysmorphism. Microcornea, okay, microphthalmia, brush-filled spots, then pinched root of the nose. These are all suggestive of different syndromes. Similarly, some other presentations like low set of the ear or malformed ears, upward pinching of the nose, long philtrum, inverted V-shaped upper lip. Okay, so this is also common in muscular dystrophy. There is one more type of muscular dystrophy where there is an inverted V shape of upper lip. It is called as, I'm not remembering. Yes, inverted V shape. It's one of the important differential diagnoses for muscular dystrophies. Okay. It's autosomal dominant condition. Anyway, a pointed chin, then small triangular face, upward and downward slanting. Again, on the inspection, suppose if there is any precordial projection and excavation, that means in the apical area or apex beat area or precordial area, there is overworking, over prominent. Okay, we have to look into that. That's one of the inspection finding. Okay, or any abnormal pulsations are appearing in the anterior part of the chest or precordium. So then we have to look into the systolic thrills, continuous thrills, diastolic thrills, etc. So these are some of the clues that this child may have some of the cardiac problem. Now again, antenatally, cardiac problems are also common when mother is not taking the folic acid and as well as these folic acid tablets. Okay, we know that importance of the folic acid in the formation of the neural crest and neural tube, etc. So along with so many congenital problems related to the CNS, there may be also sometime the cardiac problems. But more importantly, the history of drug intake is very important, especially aspirin and some of the NSAID, okay, non-steroidal anti-inflammatory drugs. So that plays a very important role, because the NSAIDs will going to block the prostaglandins, so which used to maintain the patency of the great vessels of the heart. Now we know that two great vessels are the aorta and pulmonary. So these two great vessels never collapse. Why they do not collapse is there are some prostaglandins which keep them dilated or keep them patent. Okay, the drugs like NSAID, aspirin, etc. So they actually block the prostaglandins. If mother is taking such a drug during the fetal period, okay, during the antenatal period, the fetus may this drug may be passed on to the fetus, and fetal prostaglandins which are present in the great vessels may be get blocked, leading to constriction of these two important tubes, great vessels, and that leads to number of congenital cardiac problems. Anyway, as I told, one of the important syndrome with which we find the cardiac problem is Williams syndrome. If you look into the Williams syndrome, the Elfin phases will be there, mental retardation will be there typically. Okay, so especially in case of Williams syndrome, the mental retardation will be pronounced with age. As the age increases, the mental retardation increases. Elfin face means hypoplastic mandible, small chin, large mouth with the patulous lips, blunt unturned nose, and depressed nasal bridge, a low set of widely set ears, hypertelorism, etc. will be there. Okay. So similarly in Down syndrome, we will have the cardiac problems. Marfan syndrome, of course, in Marfan syndrome, it's not actually acynotic disorders or something like that. This mitral stenosis, etc., is common in Marfan, because Marfan syndrome, where the collagen tissue is very important for the formation of the valves. So in the Marfan syndrome, we find the problem with the valves. Okay, in the valves. So Holt-Oram. One more is Holt-Oram syndrome, Williams syndrome, Holt-Oram syndrome, Down syndrome. So there are many syndromes where we have cardiovascular flexion. Only thing is, whenever you find a case of syndrome, or you think that this may be a case of syndrome presentation, immediately auscultate the heart. That's all. That's the message. Okay. Now, one of the major type of acynotic heart disease is ASD. Okay. ASD is one of the major type, isn't it? We have seen VSD, ASD and PD. Now, in the ASD, suppose ostium secundum type. There are many types are there in the ASD. One is ostium secundum type, that is 75%. Ostium premium type or sinus venosus 10%, and unroofed coronary sinus. So these are the different types of ASD. ASD, that means जो है fossa ovalis actually primary. There are two openings will be there actually, primary ostium and secondary ostium. Sometimes primary ostium may be closed or secondary ostium may not be closed. Sometimes secondary ostium is closed or primary ostium not closed. Okay, both leads to ASD. In that, ostium secundum type is 75%. Okay, primary type is less. Now, suppose if the ASD is there, we know that ASD most of the time is asymptomatic, and most of the time it is not diagnosed, or accidentally it may be diagnosed. That's a different issue. Otherwise, clinically it is very difficult to diagnose ASD because there will be no symptoms. It is not affecting much. Okay, so ASD with the normal JVP and the systolic thrill in the pulmonary area. Suppose ASD is there and child is not having any JVP, but systolic thrill is there in the pulmonary area of auscultation. If you find a systolic thrill, that indicates that this particular ASD shunt is quite bigger. It's not smaller one. Okay. Now in ASD, usually there will be also sometimes wide split of S2. S2 sound will be wide split. S2 is produced by the closure of the pulmonary and as well as aortic valve. So SP split will be there. Murmur is very soft. Usually ASD murmur is very difficult to identify. Okay, it's very soft murmur. So the hollow mark is, if you want to identify the ASD, the hollow mark is the wide second heart sound split. That's very important. With the very murmur may be heard, may not be heard, but split. Okay, split, wide split S2. S2 is widely split. So that's commonly seen because S2 means there is closure of the aortic valve and pulmonary valves also. And if there is a ASD, which is a large one, okay, so because of the pressure changes, your P2 component is not able to close in time, and that leads to a split. If the both are closing at a time, there is a single sound. If the both the valves are closing at a different time, you will have a split sound. But here it is a wide split because in the right side of the heart, because of this large ASD, a lot of pressure changes are there in the atrium, and that's the cause. If you go for ECG, it is quite easy. In ECG, you have sinus rhythm and as well as prolonged PR interval. Okay, now come to the ASD is over. Now come to the left to right shunt. Lot of matter has been already spoken about this left to right shunt. Okay. Now left to right shunt can occur at different sites also. Now at the ventricular area, that means both the ventricles, in the ventricular area the shunt can occur. That's about 20% cases. Okay, in the ventricular area the shunt, that means septum, ventricular septum, the shunt can occur. That is 20% of the cases are of this. Okay, now there are three presentations of this VSD, which is one of the most common cause for acynotic heart disease. This present in the one is typical VSD. Okay, first presentation. Second presentation is VSD with the aortic regurgitation. VSD is there, along with the aortic regurgitation is also there. That means when ventricle is contracting, blood is passing through the right ventricle through the shunt. In the meantime, blood is also passing through the aorta, but in the aortic, because of the aortic regurgitation, that means the semilunar valves are not properly closed. So there will be regurgitation back of this blood back into the ventricle. So that is another presentation, VSD with aortic regurgitation, and VSD with the left to right atrial shunt. So this we know. VSD with the left ventricle to right atrial shunt. Right atrial shunt. Okay, so this is three types of presentation in the left to right shunt. Now sometimes the shunt can occur aortopulmonary level. Okay, within the ventricle at the level of a aortopulmonary level. So this percentage is about 4.7%. So at the aortopulmonary level, that means shunting. See, one shunting is there with the pure blood and impure blood happening in the ventricle. Now another shunting can occur at the bigger vessel level. That means that is pulmonary trunk and aorta. Pulmonary trunk and aorta. Okay. So one of the best example is patent ductus arteriosus. Patent ductus arteriosus. It's also shunting, isn't it? It's also shunting of the blood. Through an abnormal canal, the pulmonary trunk blood is mixed with the aorta blood. Okay. Another is aorta pulmonary window. So that's quite rare. So these are the different types of left to right shunt. Now, aorta route to right side of the heart. So many things are there. Okay, शंट है ना कि ये बहुत अलग अलग तरीके से हो सकता है. जो हम बात करते हैं वो कॉमन शंट्स का. अयोटिक रूट टू राइट साइड ऑफ द हार्ट. अयोटा का रूट से एक शंट हो सकता है राइट साइड ऑफ द हार्ट के लिए. ओके. कोरोनरी एवी फिस्टुला हो सकता है. कोरोनरी, इधर में भी कोरोनरी एट्रियोवेंट्रिकुलर फिस्टुला. ओके. देयर में भी anomalous origin of the large coronary artery from the pulmonary artery. This we have discussed in the last class. And then a small VSD will be there. Now, what is important is size of the shunt. What is the size of the shunt? If the size of the shunt is less, okay, murmur will be more pronounced. Okay, if the size of the shunt is more, there will be less murmur. Condition is worsening, but there will be less murmur. Now, if there is a moderate is there, so that means VSD can be again divided into three types: small VSD, moderate VSD, and as well as large VSD. Okay, so in the small VSD always the murmur will be more, whereas in the large VSD always the murmur will be less, but signs of a left ventricular failure or congestive cardiac failure will be more in case of a large VSD. Okay, and recurrent respiratory infections are also more common. Now we'll have a discussion that whether the shunt will go into close. Okay, so this is a commonly asked question by the patient. So spontaneous closure of the VSD, whether VSD shunt will go into close. So spontaneous closure of the VSD, don't commit to any patient कि कोई भी patient को आप commit नहीं करना है कि ये हो जाएगा. But always you have to keep the options open. Okay, because this may lead to increased incidence of shunt reversal. So that means many occasions are there where shunt reversal can occur. That means right to left, left to right जो चल रहा था वो right to left हो सकता है. So therefore you should not commit on that. Whatever may be the size of the shunt, it's the duty of a cardiologist. So they will clearly suggest. Now closure is quite common in any muscular defect. कोई भी muscular defect आ जाए, including अगर hernia भी closure हो जाता है, you know. So closure is quite common in any of the muscular defect, including that of the heart. Okay, heart, in 80% of the cases, followed by perimembranous defects. Complete closure हो गया तो भी जो है perimembranous defect रह सकता है about 35 to 40%. So this is advanced part. Okay, so closure rate is quite good in VSD, inlet VSD, and in the Swiss cheese VSD. See now, both different types का VSD है. Swiss cheese VSD, inlet VSD, quiet VSD, etc. Okay, so if the quiet VSD is there, inlet VSD is there, or Swiss cheese type of VSD is there, then closure rate is very, very rare, or closure is very, very rare, very difficult. But some other types, the closure may occur. 25% will close by 1 year. अगर वो close होने वाला है ना, नहीं close होने वाला कैटेगरी में वो नहीं आता है वो शंट, then 25% will go into close by 1 year, and 45% of the small VHD may close by 3 years. Okay, 90% may close before 8 years of the age. So anything, the closure has been not taken place even after 8 years of age, then there is no chance of getting closed. Okay, or close, the chance is almost all nil. Only 7% of the cases with the moderate large VHD and CCF in the early life will close later. See, suppose if the small VHD, that will be having good chance of closure in the later part of the life. But if it is moderate VHD, or if the baby has got VHD during early infantile life or early neonatal life, शुरू में उसको VHD हुआ, उसके बाद CCF हुआ, ठीक है, उसका कॉम्प्लिकेशन में CCF सब डेवलप हो गया, उसके बाद है ना वो क्लोज होने का चांस बहुत कम होता है, ओनली 7% है, 7% है. So these things, this much of detail is not required for us, but still for the information purpose, I have given this. Okay, one of the important thing which can cause cardiac problem, always we have to remember when we talk about the fetus and all, that's the rubella syndrome. Okay, rubella infection during the fetal life, early part of the pregnancy, that's very, very dangerous, because one of the most common complications related to rubella is a cardiac anomaly. Okay, so what are all the cardiac anomaly that can occur if the fetuses get infected by the rubella? So that is PDA, pulmonary stenosis, ventricular septal defects, etc. Apart from that, many other cataract, etc. symptoms will be also there. So this is all about acynotic heart disorders. Acynotic heart disorders. In the next class, we will discuss about cyanotic heart disorders. In the next class, we will discuss about cyanotic heart disorders.